Hey everyone, and welcome to This Explainer. Look, if you're gearing up for clinical board exams, we are in this together. Today, we're taking a really deep dive into a microscopic menace that literally revolutionized gastroenterology. We're going to strip away all the extra fluff, focus purely on the absolute must-know facts, and lock that high-yield info right into your brain. Let's get ready to crush some clinical vignettes.
Let's kick things off with a classic board question, just to get your test-taking gears turning. Imagine you're reading a patient's stem, describing this gnawing epigastric pain that actually gets better when the patient eats a meal. You scope them, and boom, you find a duodenal ulcer. What single bacterium is responsible for up to 70% of these specific ulcers? If you're already shouting the answer at your screen, well, you know exactly where we're heading today.
Here's our game plan for today. We'll quickly hit the high-yield biological basics, look at key disease associations, dive into gastritis patterns and risks, cover diagnostic testing strategies, and then wrap it all up with treatment and eradication.
All right, part 1, high-yield biological basics. Let's get right into the rapid-fire microbiology facts that examiners absolutely love hiding in the very first sentence of a question stem. So, Helicobacter pylori. It's a gram-negative spiral bacillus. It's microaerophilic, meaning it likes just a tiny bit of oxygen to thrive. Interestingly enough, it is almost exclusively acquired in childhood, usually tied to environmental risk factors like crowding. And once it's in there, it's essentially setting up shop for life unless we go in and eradicate it. It does its damage using 3 massive virulence factors. You've got Ka, which is directly linked to inflammatory changes in cancer risk. Then there's Vaca, which forms these highly destructive pores and cells, and finally Baba, which basically acts like an anchor, tightly binding the bacteria to blood group antigens on the stomach lining.
To put this into perspective, it is staggering to realize that roughly 40% of the entire global population is colonized by H. pylori. That's almost half the world, and humans are its only important reservoir. So, the takeaway here? You will absolutely see this in clinical practice over and over again.
Okay, let's dive into this next concept, because understanding urease is absolutely crucial. The stomach is essentially a vat of highly concentrated destructive acid, right? So how on earth does this bacteria survive in there? It uses an enzyme called urease as its main acid resistance mechanism. Urease hydrolyzes urea into ammonia, and that ammonia creates this localized protective alkaline microenvironment right around the bacteria. It's kind of like it has its own personal antacid force field. And keep this in the back of your mind because this exact mechanism forms the underlying basis for our absolute best diagnostic tests.
Moving right along to Section 2, Key Disease Associations. Exam writers love testing our ability to connect the bug to the disease, but they also love testing what it does not cause.
It is vital to know exactly what H. pylori triggers. First up, peptic ulcer disease. It's responsible for about 70% of duodenal ulcers and 50% of gastric ulcers, and eradicating it virtually wipes out the chance of long-term relapse. Second, it drives distal, non-cardia gastric adenocarcinoma. Notice I said distal. The cardia region is not associated with H. pylori. That is a super classic exam distractor right there. Beyond the stomach, it's associated with MALT lymphoma. And get this, eradicating it can even normalize platelet counts in patients suffering from immune thrombocytopenic purpura, or ITP.
Now listen up, because here is a massive board alert you cannot afford to miss. We know up to 70% of low-grade MALT lymphomas will magically melt away just by giving antibiotics to kill the H. pylori. But if a patient's MALT lymphoma has this very specific genetic translocation, T1118Q21Q21, it will absolutely not respond to eradication. That specific translocation means you're dealing with a true malignancy that is going to require chemotherapy or radiotherapy. Do not miss that exception.
All right, that brings us to Section 3. Gastritis patterns and risks. It turns out, where the bacteria actually decides to settle down in the stomach completely dictates the patient's clinical destiny.
Now, what's really interesting here is the heavy contrast between these two divergent patterns. Examiners love testing opposites, so pay attention to this. If the bacteria causes antral predominant gastritis, it destroys somatostatin cells. This actually leads to high acid production, which gives you duodenal ulcers, but thankfully a low cancer risk. On the flip side, if you have corpus predominant or pangastritis, the bacteria damages the acid-producing cells themselves. That results in low acid, gastric ulcers, and a highly elevated risk for gastric adenocarcinoma. So 2 totally different locations giving you 2 completely different clinical outcomes.
Let's pivot to Section 4, Diagnostic Testing Strategies. You understand the pathology now, but test makers really want to know, which test do you order and when do you order it?
And this brilliantly illustrates the diagnostic matrix we need to memorize.
pitting invasive against non-invasive options. On the invasive side, doing a biopsy for a urease test is fast, but watch out, it'll give you a false negative if the patient is currently on a PPI. Histology is great because it actually visualizes the inflammation pattern. Culture is super specific, but it's slow, though it is literally the only one that gives you antibiotic susceptibility. Now, on the non-invasive side, the urea breath test is highly accurate and usually the preferred choice. The stool antigen test is also accurate and definitely cheaper. And finally, you have serology, which is checking for IgG antibodies.
Okay, big red flag here. Serology is not suitable for confirming eradication. Why? Because it simply cannot distinguish an active infection from a past dead one. Even after you successfully kill the bacteria, those IgG antibody titers fall incredibly slowly. We're talking well over 14 weeks. So if you check serology a month after treating a patient, it's still going to be positive, and you might accidentally retreat a perfectly cured patient. Never use serology to check for eradication.
Finally, let's bring it all together in Section 5, Treatment and Eradication. When exactly do we treat, and how do we get the job done?
So, there are definite hard indications for treatment. If a patient has documented peptic ulcer disease, whether it's active right now or in their past history, or if they have low-grade gastric malt lymphoma, you absolutely have to treat them. The standard regimen is a proton pump inhibitor mixed with 2 to 3 antibiotics for about 10 to 14 days. Though recently, using vonoprazan combined with antibiotics is yielding even higher eradication rates, which is awesome. Oh, and a critical exam detail here. You must avoid using clarithromycin if the patient has had any prior exposure to it, because primary resistance is just way too high.
Okay, so you gave them the meds, now you have to confirm the bug is actually dead. But timing is literally everything here if you want to avoid a false negative. You must wait a minimum of 4 weeks after finishing the total treatment before you even think about retesting. Breaking it down further, you need to wait at least 2 weeks after they stop taking a PPI, and you have to wait 4 to 6 weeks after they've taken any antibiotics or bismuth. Commit these specific numbers to memory, guys, because they are incredibly testable.
So what does this all mean? We've spent this entire explainer figuring out exactly how to hunt down and destroy this bacteria. But I want to leave you with kind of a provocative twist. Should we actually be eradicating H. pylori in every single asymptomatic patient we find it in? Well, the surprising data says maybe not. Because it lowers stomach acid in some patterns, having H. pylori is actually incredibly protective against gastroesophageal reflux disease, Barrett's esophagus, and esophageal adenocarcinoma. By aggressively wiping it out in someone who has 0 symptoms, we might actually unmask or completely worsen their GERD. It's wild, right? It completely challenges that eradicate all mindset and just proves that in medicine, things are rarely ever purely black and white. Thanks so much for hanging out with me for this explainer. Keep all these high-yield concepts fresh in your mind as you study, and I will catch you next time.